Hello, everyone. I am humbled and privileged to moderate the Health, Equity, and Inclusion track. My name is Nedret Sahin. I am originally from Istanbul, Turkey, and I've been calling Boston home for the last 12 years. And I've really been thinking about how I want to introduce the talks today for a while now. It wasn't until this morning, actually, when I made time for stillness, thanks to psychologist, author, and teacher of meditation, Tara Brach, that what I wanted to say became clear to me. The three talks today are going to share stories that are often excluded from conversation, the experience of Black and Indigenous communities. We will start in Kenya and Eswatini, which you may know as Swaziland. We will make our way down further south to South Africa, and then come back to this country, the stolen land of many Indigenous tribes. I want to remind everyone that the talks today are not white saviorism, although you will be hearing some from white folks. This is inclusive and participatory design in practice. And to kick off our journey, I'd like to introduce Senior Design Associate Christina Hanschke and Behavior Architect Namiya Jain from Final Mile Consulting. Together, they are going to talk about how the rest of the world can learn, but particularly the United States, can learn from developing countries' approach to healthcare. Hint, it's contextually appropriate approaches that support local ownership and build skills and capacity to ensure sustainability and scalability. With that, Namiya and Christina, welcome. Please feel free to turn on your cameras when we get to, actually just say hello now to everyone. Just so you all know, Namiya and Christina have pre-recorded this talk because Namiya is based in India and it's very late for her right now. So they can interact with you in the chat during the presentation. We're not going to be pretending that they didn't pre-record this. And with that, I will get started and share their presentation. And then in the last 10 minutes, we'll come back together for questions. As a reminder, you can use the chat function for questions, or you can use the Q&A function within the sessions area. If you use Q&A, you can actually upvote each other's questions, and I will look at those at the end of the presentation. All right, without further ado, I am going to share their presentation.
About US current approach to healthcare and challenges faced by the system. Then we'll talk through the community-centered based approach to healthcare in the developing nations. Further, we'll discuss how we can reconceptualize the healthcare system overall. We all know that US spends more than the peer nations on healthcare and yet experiences poorer outcomes. US healthcare system has primarily delivering care through hospitals, clinics, physician offices, essentially the formalized care. Roughly a third goes to hospital care, while professional services make up roughly a quarter of the spending. There is an emerging yet limited role of communities and non-clinical setups for care delivery. The US healthcare system is designed based on the assumption that we as humans are rational beings and we will always do what is expected of us. We only need to be given health information and we will seek care whenever necessary. This leads to a burden of care seeking is solely on the individuals. The expectation is that an individual knows how and when to enter the healthcare system and navigate it perfectly. However, we do not always make rational decisions, right? We know that decisions are based on a number of other contextual and social factors. And then with COVID-19 hitting the world, the US healthcare system was stressed. Even before the pandemic, most hospitals in the US were working at near to full capacity, with only 1 in every 3 US beds being available on any given day. And as the pandemic hit the US, hospitals experienced limited capacities for both testing as well as treatment. Including providers, frontline workers, were burdened with hospitals becoming the epicenters. While the system faced these behavioral challenges even before the pandemic, they've been highlighted in the pandemic context. Poor care-seeking behavior being, one of the first ones that I'll probably talk about. During the initial outbreak of COVID-19, most countries were testing either the self-reported or contact traced individuals. However, the low-risk perception of contracting this disease, the existing fear within the communities regarding the virus, and the lack of healthcare system became some of the reasons for poor care-seeking behaviors. Another big challenge was ensuring compliance to lockdowns, quarantines, wearing masks, etc. during the COVID-19 outbreak, and this was primarily due to the lack of trust and the low perceived risks in the community. Parts of US have also witnessed protests against extended lockdowns, mask usages, closed schools and restaurants. Being told what is to be done, for example, wearing masks, social distancing, were taken as restrictions against their individual rights. While resistance could be, a result of lack of trust in the governments and the healthcare systems, it can also be attributed to the lack of perceived control over the situation. And hence, violence and resistance becomes, ways of exerting the control. Healthcare providers were stressed and overburdened. They were at increased risk of poor mental health due to their role as care providers. The other vulnerable population that also faced the impact of outbreak includes the non-COVID patients. Overburdened hospitals resulted in reduced bandwidth for the non-COVID patients, resulting in the patients avoiding the hospitals due to the fear of being infected while visiting them. Most developing nations have experienced epidemics in the past and have established networks and systems outside the hospitals that help their healthcare systems to control the spread of the disease as well as reduce the burden on the hospitals. Over the years and through various epidemics, they have advanced their model of care to reach the communities. Their healthcare systems are supported by community network comprising of community healthcare workers, volunteers, regional leaders, community care centers, and primary care units, and sometimes even mobile clinics and camps. Community healthcare workers are the most important element of the community-centered care. The role involves community sensitization, volunteering, and providing primary care within the communities. They bridge the gap between the healthcare systems and the communities. Community healthcare workers helps in maintaining the community sentiment in times of increasing health crisis or pandemics. They also they also collaborate with local leaders, youth, communities to increase the community trust in the healthcare systems. Their increased role in providing primary care helps in reducing the stress for the larger formalized healthcare system. Along with the community healthcare workers, there is also an increased involvement of religious leaders, youth, community leaders, local providers, etc., who take up ownership, who volunteer and support the overall efforts of healthcare within the communities. They may not be trained as community healthcare workers, however, they work alongside them to support their efforts. They may approach and encourage other people in the community. During the Ebola pandemic, community care centers were set up in the community in which the members were engaged on a daily operation basis. Giving them more control in planning and supporting in delivery care is the key to build trust in the communities. Familiarity also helps the locals to manage the community sentiment and build trust and of course, reduce resistance henceforth. The involvement of the communities in the healthcare also helps in reducing the stress of the healthcare system. And this is primarily done with the help of primary care units. Talking of primary care units, these are generally set up with communities that provide basic primary care within the communities. They help in reducing the burden on the hospitals. They become the first point of contact whenever the communities seek care. They are approachable and, of course, more frequently visited by the patients. In the past epidemics, community-centered care have reduced the burden on healthcare providers by screening patients outside of the walls of hospitals and encourage clinical care to only those who needed it. And for example, for long-term treatments, decentralization of basic care helped in removing the burden from the hospitals as well. And this is done by providing extended care to the patients within the community or home. These provide extended care post the initial diagnosis and treatments that happens within the walls of the hospitals. This improves access to care, it reduces patients and provider costs, and it also improves in outcomes. In Indonesia and India, for example, with tuberculosis patients, it has shown better adherence behavior and improved treatment success rates. The last but not the least is the element that are more of temporary establishments. In the past, they've been a part of major community responses to prevent diseases. These are set up to provide quick prevention support in the communities. In West Africa, for example, pandemic response during Ebola, temporary facilities were quickly erected and staffed by medical community volunteers, and they acted as triage centers. They tested isolated patients and treated other sicknesses. In various parts of Africa, with the ongoing HIV programs, various camps and mobile clinics are organized within the communities as temporary establishments for sensitization. These elements, again, help the healthcare system to ensure population health, reduce the impact of pandemics, which in turn helps in reducing the stress on the healthcare systems. They also help in providing basic care, which reduces the load on hospitals and ensures the non-pandemic patients are served and hence improving care-seeking behaviors. All these elements play a very important role in the healthcare systems of most developing nations. This is a consolidated view of all the elements that exist in different healthcare systems of the developing nations. These elements interact with the patients frequently. The individuals are often reached by various community health workers who sensitize him to take up prevention measures and maintain his health. Being a part of the community, they might also meet various community members who are volunteering for various care services within the communities. These interactions also involve flow of information regarding maintaining health as well as seeking health. These interactions also encourage testing, early diagnosis, and treatment of various diseases. In a scenario, for example, where the individuals might show certain symptoms of a disease, he could either be advised by the community healthcare worker, he might reach out to the primary care units and the community care centers. These elements are generally equipped to diagnose the diseases and provide medication and treatment. The individuals may also be referred to the bigger hospitals that are suited outside the community. On being diagnosed with the diseases that require long-term support, medication, and treatment, the hospitals refer them back to the decentralized care within these communities. Here, the decentralized care helps in ensuring compliance and adherence to the treatment and is taken care of. The US for now has already set up a great connection with patients accessing the formalized healthcare system. However, the formalized care system is mostly treatment focused and it's physician-led. It involves experts, equipments, facilities to initiate and implement treatments. It is not enough to overcome the behavioral challenges of poor care-seeking behavior, compliance, and adherence. It expects a pull from the patients for care-seeking behavior. The burden of the compliance and adherence is also left on the patients post the treatment. The sentiments of the community are not managed in the current design. To overcome some of these challenges, there is a need to reconceptualize the healthcare to include and introduce an increased role of communities, focusing on both curative as well as preventive care. Here, by establishing the community links, we have the opportunity and the need to strengthen the system that takes the burden off the individuals, builds the trust in the healthcare systems, and improve the overall population health. This can be done by building capacities within the communities, by leveraging community leaders, leveraging youth leaders, and of course, collaborating with the community healthcare workers. Increased involvement from the community would help in decreasing the burden on the healthcare system and building these capacities and empowering the communities would result in a more integrated approach. And now my team member, Christina, would also talk about one of the ways in which Final Mile has been involved in building capacities within the communities.
Thanks, Namiya. So one way that Final Mile has worked with strengthening communities is through the LISTEN model, which is a project funded by the Bill and Melinda Gates Foundation and led by Georgetown University's Center for Global Health Practice and Impact. So LISTEN really focuses on building and leveraging communities of practice from the local level all the way up through country leadership, building those connections horizontally and vertically to address high rates of HIV. We were initially brought in to see how HCD could be utilized within LISTEN in Eswatini and Kenya. So first we met with some of those communities and we mapped that journey of a community of practice within LISTEN. So we saw what elements we could leverage with behavioral principles at each stage so that we could build collective efficacy and promote reciprocity with small commitments. What happened was we really observed that these communities of practice are experts in their understanding and their knowledge of their specific context, and that they are also experts in knowing what types of solutions would and wouldn't work. So our role really became, how do we help them bridge that gap? And when we discuss problem solving. So with this journey in mind, our team made the recommendation to build tools to support these communities of practice using human-centered design as a problem-solving process. But when we took this to the countries, they came back and they said, we don't need just tools, we need training of how to use HCD within this process. So that's what our team did to work on. So we worked with these LISTEN country leads to create a plan for sustainability. And what we came up with were 3 sets of trainings. These included an HCD facilitator training to have a set of experts there, a multi-week training to build capacity. Then we have an HCD general training, which is a shorter, more compact multi-day training with a goal of learning about and applying the HCD process. And finally, an HCD overview for leadership, a 2-hour session that we could share how HCD is being applied within LISTEN, what the benefits are, so that that could create buy-in and support for HCD within leadership. So as you can see, we're building in trainers, we're building in knowledge, and we're building in support for HCD. So we wanted this to really be a co-design process. And what we did was first we established an HCD working group with representation from the Eswatini and Kenya LISTEN country teams, as well as our consortium partners with Georgetown and Desireline. So these country members not only worked on LISTEN, but a lot of them were members and worked for their Ministry of Health, Ministry of Education, NOC within Kenya, and they came with roles such as regional HIV coordinator and program officers. So we had a co-design workshop with the output being learner profiles for each of these curriculum, as well as an outline. Then our team with Final Mile, we built out that content of this first general HCD course, getting input from our team members along the way with bi-weekly check-ins. And finally, in January of this year, we hosted virtual pilots of this HCD general training for both Eswatini and Kenya. The pilot was full of learnings. Our team is still working on incorporating those revisions there. And yet our intention in this process, it's not that the pilot is a one and done knowledge distribution that's one way. It really needs to be more for this to be a sustainable process. So what we really focused on, we shared HCD mindsets and an HCD process that was LISTEN specific and country specific. We not only taught what those ideas and those concepts were, but we applied them through activities and through methods of addressing HCD with real problems their communities are facing. At the end of the pilot, we had the participants create a roadmap of activities that they were going to accomplish within the next month. And then we also established an HCD community of practice. So now every other week, our Final Mile team hosts a call with the pilot participants with the goal of supporting their efforts applying HCD, providing any resources, and capturing what information has been helpful, what would be helpful, what are we missing that we need to add. And more importantly, it provides a space so that members across countries and counties can hear and connect to that horizontal level to hear what's working, what efforts they have, what's struggling, where they're struggling. So finally, again, we really continue to learn our team as we work together, what's going to be relevant, what's going to be needed within their context so they can work with their community members. And so our team really has these kind of guiding principles as we work on this project, is that our Listen country members are really our partners. They have their areas of expertise, we have ours, and we work together to leverage both of those. We also realize that we need to cultivate an HCD mindset, a buy-in with that, before we can even get into the HCD process. Fortunately, a lot of the elements of the HCD mindset coincide with the values of Listen in general. And finally, our role is really facilitator and capacity builder, with the ultimate goal of transitioning ownership there. So we are not the keepers of the knowledge, we are assisting and we are helping build those connections so they're set up to continue this work. So we just wanted to thank you again for our time. That's just an introduction to one of our projects, to our work. Please feel free, there is a paper out there about phase 1 of Listen on Gates Open Research, if you'd like to read more about that. And then Final Mile, we've got our corporate or company website, as well as some thoughts about the research project. But thank you all so much for your time, and we look forward to hearing from you.
Thank you so much. I'm gonna clap for everyone who's also, I'm imagining, clapping on their end. Thank you. Some of the things that strike me as I'm listening to that was just around how you acknowledge this idea of building trust and familiarity to reduce resistance and give people the tools that they need to solve problems that they're facing, right? Oftentimes in design, it's like, oh, like what problem are we solving? And especially as folks who are outside of those communities, we come in and we're like, oh, let me fix this problem for you. And I love that that's not what you did. I love that that's not what you did. I'm going to stop sharing my screen so we can see you all here. Cool. Well, this is just a reminder for everyone in the audience to put in questions if you have any for Namiya and Christina. I love that you brought in kind of that example of a case study to really bring that to life. I think that was really, really powerful. Is there anything that's coming up for you as you watch your recording?
No, just really thankful, and I think I asked the question in the chat. We're really interested in hearing, some of these community care centers in the States. I know one of the organizations that Namiya and I looked at was Oak Street Health, because they're engaging there, and it was one of the initiatives when COVID started. I'm here in Chicago, but they talked about hiring contact tracers within communities, with potentially that transitioning into community health workers. So I haven't followed up about that, but that was something that was really interesting and something I was interested in following. So.
How about you, Namiya? When you watch that, is there anything else that comes up to you? Any questions that you have for yourself or for anyone else?
I think we do have a question in the chat here, which is, can this model of community-oriented design be applied as a framework to different communities? So definitely, I think applying we basically came up with a couple of models, capacity building folders, right, that we sort of disseminated within the communities through Listen. And when we did that, the intention was to sort of design for the communities. However, with different communities, context would matter a little bit, and there would be a need for us to probably come in and tweak it a little bit based on overall. As a broad idea, I think it's definitely very, it's easy to contextualize into, we can definitely apply. And of course, Chris can talk a lot more about that, right?
So I think one of the things that we've learned is when we're talking about design for different communities, and I spoke to it a little bit, it's not just an education. There's all these different courses that are online, and access is great and it's available. And some of the members of Eswatini have taken those courses. There needs to be, as one of our participants said, like applied to the African context. It's great to learn about how Airbnb did their work. It's a little outside of these really complicated, wicked problems when they're dealing with high rates of HIV, and then unemployment, poverty, access to clean water. So I think what we're trying to do, and really centering around it's Wenger's work of communities of practice, is how do you kind of create that, build these different layers of experts that come in there, create a community that can share and learn from each other. Because I think a lot of us know, I think my latest analogy that I like is HCD or design is a recipe. And once you get the hang of it, you can improvise and adapt and get it because you know what the key components are. So I think we're just really trying to support the ownership there, setting up these different areas. And again, we're iterating and seeing what works and what doesn't work, and kind of see, because we do want this to be sustainable, owned by the community. And then we slowly, over the next 3 years, trying to transition ourselves out of there.
I love that. I love that. We have another question from Niku, I believe. What were some of the unexpected learnings you had in this experience, and which assumptions did you find were challenged?
Well, I think I spoke to it briefly, but it was walking in and being like, great, we're going to design tools. We found this. We've already got these tools. We'll go and, you know, maybe we'll do this other thing where we make a course. And so for the countries to come back and be like, no, we need these trainings. We need these people to have these trainings. So when we expand and when we do that, so that was a big learning. And I see something here with the communication. That's been a really big learning. Our pilot, the terms we use, it's in English because that's standard. Obviously, that's not the first primary language for everyone that we had worked with. So even hearing things about, we don't need to put these fancy labels or use terms, industry terms on things for people to use it. So we always are trying to look for that balance of what's going to work with their context, their understanding. You know, HCD is this whole around the world process people know. So how do we kind of make them aware of that? What terms can we toss? We toss behavioral archetypes. We put that out there because we're a behavioral science firm. That was just unnecessarily complicated. So that's something we changed, you know, and we're probably annoying our participants, but we're always asking them what works, what doesn't, what was really confusing here. So we're getting that feedback.
Yeah. One of the things that I thought was really cool that you said in this is that, you know, people are experts in their own experience. Was there any moment where you felt like you made maybe an assumption that they weren't, or you did something where you're like, ooh, that was kind of an ouch moment of like me realizing that I need to empower people, and it kind of just step out of the way? And maybe you could talk kind of more about your journey in getting to this point, right? As designers and behavioral architects, because I just find that there are a lot of people that are either early in their journey of getting there, learning which language to use and how to approach issues like this. I'd just love to hear from both of you kind of some of those like bigger learnings along the way.
Do you want to go ahead, Namiya? Or?
No, Chris,
I know you both
I think she's a lot more.
Yeah, because I know you've both done research in different countries, right?
Yeah.
And that's how you talk, because I know, Christina, you've done work in Indonesia and India, and Namiya, you've done work in Africa and India and the US. So I'm just curious to hear like those different contextual differences.
Personally, I think context, as a team, all of us anyways believe in the fact that context definitely matters a lot, right? Even when we're solving for the same problem statement in 3 different countries, one of the projects that we're right now doing is understanding hesitancies around, for example, COVID vaccines, right? And the difference between the 3 countries is huge, right? And even with the context being dynamic, for example, even that makes a lot of difference. And with things changing all the time, people taking decisions in the go of the moment when things are so dynamic, context definitely becomes very, very important. And we believe that behaviors are definitely, impacted by the norms that are there, the societal norms that are there in the, community overall. But it's also the place that they live in, the other people who are around, their beliefs that come from these communities and the context. And for example, within Africa, their goals or in life or their everyday looks a lot more different than what it looks like for a person in India versus a person in the US. So I am constantly fueled by some of these changes, I think, and always like to look at the context first, and anything else is the layer on the top of it.
Yeah, I mean, I'm constantly learning. My first trip to Eswatini was come talk to this group about human-centered design, and I did not know where to start, because I didn't know the group it was doing that. And so I think learning and we're working with such talented people who are doing such amazing work with the Ministry of Health and the Ministry of Education and with NOC, that I need to link onto, like, they're using things like measurement and evaluation at M&E standards. Some of them have their own problem solving processes. So it becomes not just, hey, I've got this great idea, but it's, what else do you know about that? How can I help make those connections? Or can we toss out our idea for this because you've already got this thing in place that you've been using? So I think I'm constantly trying to learn from all my mistakes, my missteps, and just getting to know the people that we work with. And I do have to say, we wanted so badly to be in person to run these pilots, but even doing it virtually, my colleague and I, we had an activity of sharing an embarrassing moment and then talking about how you could reframe that as a learning. And so I shared a very embarrassing moment and everybody was on mute. And so I'm just like, okay. And all of a sudden they took it off and the whole room's just laughing. And so to find those connections and those moments and to be a bit vulnerable, and put yourself out there, I think that's been a big learning too.
Okay, last question. If someone wants to do this type of work, what are the most important skills that you think they need to work on honing?
Chris, would you like to go first?
Absolutely not.
I think one is just constantly keeping the environment extremely light, because we deal with very, very important and serious problems at hand all the time, and it's very easy to get flowed into those sentiments, and even within the team or when you're working out in the field. So one is just keeping the mood light, and I think that's one of the things. The other thing is also, I think, forgetting where you're coming from, but also acknowledging the fact that the person in front of you might not forget it. So you will always have to keep yourself out there, be vulnerable, show them, under the skin, we're all humans. I think one of the things that it was a new experience for me, but when I was working with people in Africa, they suddenly looked at me as somebody with a different color and somebody who came with an authority and wanted to make a difference and didn't understand them well. So just being vulnerable helped a lot. I think those two things for me work a lot when I'm in the field. Yeah.
And I think just to add to that is something I really like about our company is we have such a focus on the learning mindset. So we're always learning, always learning. And I think, Namiya, something you said, you can't tell on screen, I'm almost 6 feet tall. This is me with a little bit of color. I am so white. But realizing the privilege and what Namiya said, the power dynamics and what I bring into the room and how I need to, address that, it's just being aware of what all those things are. And I think just observing and taking things in and looking for the way people do things differently, but just like Namiya said, how we can connect on similar elements.
I love that. Thank you both.